Welcome to ATCM, the Emergency Medicine channel. Today let us discuss about toxic alcohol poisoning. We get lot of cases who have alcohol induced adverse effects to emergency room. It all depends on blood alcohol level. Percentage of blood alcohol level can determine the clinical findings of alcohol induced acute problem. So depending on the level, 0.033 to 0.12%, patient can have flushing of face, improvement in mood, higher self-confidence, less anxiety, short attention span, lack of fine motor coordination, impairment of judgment. So that is a first stage. From that you can see the last stage, blood alcohol content 0.35 to 0.80. That's a very high level. Patient develops coma, lack of pupillary response to light, life-threatening respiratory distress, severe heart rate reduction, bradycardia, hypotension, shock, then it may lead to death also. So all these clinical findings depends on the blood alcohol level in percentage. So patient can have abnormal behavior, ataxia, agitation, respiratory distress, hypotension, bradycardia, shock. Variety of symptoms can be there in alcohol induced problem. Mainly it affects the central nervous system. Now when we get ethanol poisoning, we always send ethanol levels to toxicology lab. According to the blood levels, we can also get symptoms like blood level more than 100 milligram per deciliter, patient can have ataxia. At 200 ml per deciliter, patient will be drowsy and confused. At 400 ml per deciliter, patient can have respiratory distress, bradycardia, hypotension, shock and all. Most of these patients, we take a ABG. Whenever we see a patient who is having smell of alcohol, we have differential diagnosis like ethanol poisoning, methanol poisoning or other toxic alcohol induced problems, or sometimes it can even poison like herbicides or other toxic materials, because they can mix all these things with alcohol and take. So we always take a ABG to know whether it is alcohol alone or something else like toxic alcohol is there, or any other problem like lactic acidosis or electrolyte imbalance, because most of the ABG machines give us pH, PaO2, PaCO2 and electrolytes, creatine, like that various parameters are available in point of care ABG machine. So from Osmolal Gap we can even calculate the level of ethanol levels in our blood. It is possible, but normally we don't try to do all these things. We always send ethanol levels to toxicology lab and get the report. So whatever it is, the standard formula for blood ethanol level in milligram per deciliter equals to 4.6 times of osmolar gap. You can calculate your osmolar gap by serum osmolality minus calculated osmolality. Osmolality can be calculated by 2 into sodium plus glucose by urea in millimoles per liter, or we can when we have BUN, that BUN can be divided by 28 to get urea. So it's a complicated formula, so we don't try all these things in emergency room. Whenever we have a patient who is having smell of alcohol, we always take ABG machine. We'll see acidosis, it will be a high anion gap acidosis. Then always we send a sample to toxicology lab to analyze what type of alcohol he has taken. Now once you understand that this is a simple alcohol, then we can treat the patient with gastric lavage is very useful if the patient comes in less than 1 hour. In a massive ingestion, even after 1 hour, it will be useful. Charcoal is not very useful in any type of alcohol induced problem, whether it is ethanol or toxic alcohol related problem. IV thiamine is very important because most of the alcohol problem, patient can have thiamin deficiency. So when we give dextrose, there will be acute reduction of thiamine in the central nervous system, and patient can have altered behavior and thiamine induced wernicke's encephalopathy and all. So thiamine should be given either along with dextrose, or thiamine should be given as an initial bolus you can give thiamine, then add dextrose. Both are possible. So thiamine plus dextrose should be given. Never give dextrose alone, that will produce severe wernicke's encephalopathy if there is an already pre-existing thiamine deficiency. Now lorazepam or haloperidol can be tried if the patient is agitated and aggressive behavior is expressed by the patient. Mechanical ventilation is can be useful in a patient who is having respiratory distress, because here we cannot use NIV. Most of the patients are having altered behavior, low GCS and all. So NIV is not a good choice in respiratory distress. Mechanical ventilation will be a better choice. It can even protect the airway also. You can see the metabolic pathways of ethanol, methanol, ethylene glycol. All these toxic alcohols, you can see that the last step will be the acid formation: acetic acid, formic acid, glycolic acid. So all these acids are dangerous to our metabolism, especially formic acid. Formic acid produces lot of complications like retinal damage or putaminal infarct, like that. A lot of abnormalities can be developed there. Now we can see the important alcohols here. One is methanol intoxication that produces formic acid. Formic acid produces metabolic acidosis, hyperosmolality, retinal damage with blindness, putaminal damage with neurological dysfunction. So these are the important findings of methanol toxicity. And you see the another important this one is that among this group, propylene glycol intoxication. It can produce lactic acidosis, hyperosmolality. This is very frequently used with some drugs we use in ICU, so we'll discuss that, but it is not clinically that important for an ER physician, because when we give such drugs, we know that this type of additive to the IV preparation can produce some of the abnormalities like lactic acidosis. So better to avoid these drugs or understand that this lactic acidosis is produced by these drugs, that's all. So some of the drugs like diazepam, lorazepam, etomidate, then phenobarbital have higher concentration of propylene glycol in their ampule. So when we are giving continuous infusion of lorazepam, diazepam or phenobarbital, there will be high chance of lactic acidosis due to this drug, but clinically they are not very important, so we will not be discussing that. But however, it can produce some toxic effects in these patients. Since it's a small quantity and it is clinically proven that may not produce major clinical hazards in the patient, so we will not discuss that. Methanol poison is very, very important because it's one of the most important adulterations into ethanol, that is a normal alcohol. Methanol is industrial spirit. It is metabolized in our body to formaldehyde and formic acid. It has got two important problems. One, produces retinal pigmented epithelial cell damage. Optic nerves are also damaged, that produces blindness. Another important problem is bilateral basal ganglia lesions, putaminal lesions. Patient can have altered behavior, abnormal movements, encephalopathy, like that. Lethal dose of methanol poisoning is 30 to 50 ml, but blindness alone can be produced by the amount of methanol required for blindness is very small amount. 10 ml is enough to produce blindness in a patient who is having methanol poisoning. So patient can have metabolic acidosis, bradycardia, shock and all, but the most important clinical finding will be snowfield blindness. That means slowly reducing decreased visual acuity as if standing in a snowfield. So initially there will be reduced vision, then there will be haziness of vision, then there will be complete reduction in the vision. It is always bilateral, but it is reversible. That is the advantage. Immediately if you treat, it is reversible, but after sometimes 1 or 2 days it will become irreversible. So diminished vision, dancing and flashing spots, dilated fixed pupils, hyperemia, optic disc and papilledema, ultimately it will lead to blindness. So any patient who is having smell of alcohol, acidosis, then visual impairment, we have to always think about methanol poisoning. Now, lab diagnosis, we always take an ABG in any type of cases, alcohol-induced problems in emergency room that shows metabolic acidosis. We have seen it is due to lactic acidosis or some other mechanism of acidosis. Whatever it is a high anion gap acidosis. We can calculate anion gap by sodium minus chloride plus bicarbonate. Anion gap acidosis is if the anion gap is more than 12, we can call it as anion gap acidosis. Now, after anion gap, one more method is there to find out whether this is due to alcohol itself, that is osmolar gap. You can calculate the osmolar gap by 2 into sodium plus glucose by plus urea. That will give osmolar gap. If the osmolar gap is more than 10, that indicates it's mostly due to ethanol, methanol, formaldehyde, ethylene glycol, isopropanol, like that, or mannitol paraldehyde. So, ketoacidosis and mannitol paraldehyde also can produce high osmolar gap acidosis. So, it is not very easy to diagnose these things only by these formulas. We have to have very good clinical findings to tell whether this patient is having alcohol intoxication, alcohol induced problem, methanol, and strong backup should be there from the toxicology lab also. Now, osmolality can also be calculated with ethanol levels. There is also another formula. You can calculate 2 into sodium plus Bun by 1.6 plus glucose by 18 plus ethanol by 4.6. So, in that way also you can calculate if the patient is already having ethanol intoxication, if the patient is already taken ethanol and if you are getting an ethanol level. But lab investigations are best, like you can ask for ethanol levels, methanol levels and ethylene glycol levels in our blood to a toxicology lab. So, definitively these results will be better than that other calculated results what we have seen previously. Methanol concentration more than 25 can produce definitive diagnosis of methanol poisoning. Ethylene glycol level more than 20 milligram, it's a potentially toxic level. Ethanol level at 400 ml per deciliter can produce complication like respiratory depression, bradycardia, hypotension and all. Some patients can have methemoglobinemia also. So, we have to always check methemoglobin levels in patients. Lactate gap is also another important aspect of toxic alcohol problem because many patients who is having this toxic alcohol, especially ethylene glycol, that can interfere with the results of the point of care machine, and it can produce elevation in the lactate without actual elevation in our body. So, it's a lab error, but even then our treatment will not change depending on this result. So, we will skip this problem. Calcium oxalate crystals can be there in urine in many patients, but here also it will not alter our treatment. So, we will not go to this aspect. Now, how to manage methanol poisoning? So, one of the steps we can see, it can be treated with ethanol, it can be treated with other drugs that also we will discuss afterwards, Formipazole. Ethanol we will discuss afterwards, but here we are talking about formic acid. We can see in this slide methanol metabolism. Formic acid is produced during the metabolism, and this formic acid produces metabolic acidosis, retinal damage, putaminal damage. All these things are due to this acid. So, the conversion of this acid into carbon dioxide and water will give benefit. That's why we have to give either folic acid 5 milligram as an oral dose, or we can go for an IV drug, that is folinic acid. That's an active form of folic acid. Folic acid has to convert to folinic acid and act here. Folinic acid directly can be given, that will act immediately, that will convert formic acid to carbon dioxide and water. So, some benefit is there for folic acid. 1 milligram per kg, maximum 50 gram, followed by folic acid tablets. Now, ethanol or Formipazole, that is the next treatment option. So, if methanol level concentration more than 20 milligram per deciliter and increased anion gap acidosis, visual symptoms, then we have to give Formipazole or ethanol. Ethanol can be given as IV or oral. So, it can be prepared in your pharmacy by 10% ethanol in dextrose water, 10 ml per kg, 10% ethanol in dextrose water IV over 30 minutes can be given. It can be given as IV or it can be given as oral route through the Ryle's tube. If that preparations are not available, then better to go for traditional alcohol. You can take 50% oral ethanol, that is alcohol, can be given through the Ryle's tube, and that also gives equal benefit. That is because it reduces the production of formic acid from methanol. That we will see how it reduces the production. Formipazole is another drug that is an alcohol dehydrogenase antagonist. Dose is 15 mg per kg in 100 ml dextrose water IV over 30 minutes, followed by 10 mg per kg IV 12th hourly for 4 doses. So formipazole can be given in patients who is having alcohol induced problem, visual disturbances or abnormal movement disorders. You can give formipazole and ethanol. If we are dialyzing the patient, because dialysis is also an important treatment aspect of toxic alcohol induced problem. If you are dialyzing the patient, then additional dose, loading dose has to be given for this patient because it's a dialysable drug. Hemodialysis is a definitive treatment for all toxicities because it can remove this type of toxic alcohols from our body. So we have to try hemodialysis if nothing is available, or if the patient does not improve, and if patient is having high levels of methanol in our body, 50 mg per deciliter, or severely affecting metabolic acidosis, or if the clinical improvement is not seen with the traditional ethanol or formipazole or leucovorin treatment, then immediately patient should be taken for dialysis. The improvement is very significant after dialysis. So we have to try for dialysis in all patients who is having visual disturbances. It is very clear that visual disturbances are reversible if we are treating early phase. Otherwise, the patient may lose his vision. So it is better to go for dialysis if the patient is having visual disturbances, irrespective of the initial treatment effects. Now, methanol associated optic neuropathy, another off-label usage of off-label drug usages. You can use erythropoietin. Actually, we use erythropoietin in patients who is having anemia in renal failure. But here we are using for a separate purpose. Anemia and renal failure, we can give 4,000 or 5,000 international units subcutaneous. But here we are giving 20,000 international units per day for 3 days through intravenous route. That is the main difference. We have to give intravenous route, and it is very high dose. Okay. So it can be tried. There are some papers which favor this improvement of optic neuritis after this toxin. You can see here, this chart will tell you what are the drugs we have to use in patients who is having toxic alcohol. So it will be difficult to diagnose a patient who is having toxic alcoholism in emergency room without getting the toxicology reports from a good toxicology lab. If we get a toxicology report fast, then it is easy, whether it is methanol, ethanol, ethylene glycol, whatever it is. But if you are not getting, better to give treatments like you can give formipazole, you can give folic acid, you can give thiamine. All these things are important. Some more vitamins are there that will explain afterwards. So immediately start the treatment. If we are not having any good result after this initial treatment, better to take this patient for dialysis. Now, some of the vitamins are also very important role in the treatment of toxic alcohol poison. You can see the steps here. Formic acid reduction can be done by folic acid or folic acid. Glycolic acid reduction can be done by thiamine and pyridoxine. That's why patients who is having ethylene glycol toxicity in ICU and all, we give all patients thiamine and pyridoxine, so that this type of errors, metabolic errors produced by drugs what we give in ICU patients or drugs what we give in patients who is on ventilator can be reduced. Sometimes it produces some clinical judgment errors when it produces lactic acidosis due to this glycolic acid. Ethylene glycol, again we have discussed ethylene glycol. Ethylene glycol treatment is same as the previous toxic alcohol we have seen. Formipazole ethanol, dialysis, thiamine, pyridoxine and magnesium. It is ethylene glycol is mainly seen in antifreeze preparations, industrial solvents. Here the oxalic acid is the problem. It produces deposits in the renal tubules and produces renal tubular necrosis, and also produces hypocalcemia, tetany, seizures, QT interval. We have to QT interval prolongation in ECG. So we have to treat according to the clinical finding. If the patient develops hypocalcemia, we have to give calcium. Tetany and seizures, you have to give anti-seizure medication. Like that, it all depends on how the patient present to you. So supportive therapy is very important here. So ethylene glycol, again formimazole or ethanol. You can give thiamine and pyridoxine that increases the conversion of glycolic acid to less severe acids, like you can see in the figure. So we have discussed about some of the important toxic alcohols in clinical practice, but in a normal emergency room setup, it will be very difficult to diagnose this type of problems. Patient come to emergency room, if whatever alcohol he has taken, come to emergency room with abnormal behavior, agitation and coma, respiratory depression. On ABG finding, what you see is a high anion gap acidosis, but it will be difficult to diagnose whether it is a methanol, ethanol, all these things initially itself. So if the patient is having difficulty in seeing, so vision is diminished, that is the most important problem in all toxic alcohol problems. So if the vision is diminished, or if there is mass casualty, like large number of patients are coming to emergency room with alcohol induced problem, then we have to always suspect this adulteration of ethanol by methanol. We have to give folinic acid, formimazole, ethanol to this patient. Then other vitamins like thiamine, pyridoxine also can be given, because these are the limited options available. And if we see that suppose the patient is not improving with our traditional treatment, better to take this patient for dialysis, because once the visual problem sets in, then it will be very difficult to reverse that problem, because it's a easily reversible condition if we treat early. But once there is a severe damage to retinal nerves, then the reversibility is very, very difficult. So it is better to dialyze this patient very early itself if the patient is having refractory problem. Thank you.